Welcome to Module 2 of the CHEMPACK program. This module covers the treatment of patients that have been exposed to nerve agents. The objectives for Module 2 include explaining signs and symptoms of an individual that has been exposed to a nerve agent, describing how to decontaminate a person that has been exposed to a nerve agent, explain the clinical effects of nerve agents, and describe the antidotes for nerve agents, as well as explain how to treat an individual exposed to those nerve agents. A key point to remember is that clinical effects may vary dependent on the proximity to the nerve agent, as well as the length of time of the exposure. Potency of the nerve agent is also an important factor. So the more contact with the agent and the length of time exposed can have very devastating effects on the individual. Often death may occur quickly within 1 to 10 minutes, depending on the proximity and exposure level. Recognition and detection for nerve agents and fourth generation agents are very important, and there are 2 acronyms that can help remember the signs and symptoms for individuals that have been exposed to a nerve agent. The acronym SLEGM is salivation or drooling, lacrimation, tearing of the eyes, urination, defecation, gastrointestinal upset, and emesis or vomiting, as well as meiosis or constricted pupils. Dumbbells can also be used in that it's defecation, urination, meiosis, as well as muscle weakness, bronchospasm or bronchorrhea, bradycardia, emesis, lacrimation, salivation, and sweating. When responding to multiple patient events, it's important to maintain a high index of suspicion. Dispatcher clues can also help in that multiple callers complaining of similar symptoms within the same area that are being affected could be a major indicator. So the description of those events from 911 callers need to be relayed to responding units. When responding to events that are suspected of nerve agents, you need to make sure that you're protecting yourself as well. You need to make sure that you avoid any unprotected skin contact with the agent or any contaminated surface or potentially contaminated people. Do not touch your eyes, mouth, nose, or any part of your unprotected skin, including after touching potentially contaminated surfaces or people, to avoid any cross-contamination. Once you do come in contact, you need to make sure that you go through decon. In selecting your PPE, it should be based on your department or agency's SOP with consideration to what your job task and your potential for exposure hazards are going to be. Conduct your decontamination as soon as possible after a known or suspected exposure to a fourth generation agent or any other nerve agent, with particular emphasis on removing any liquids from the agent or liquid agents from the skin. Additional actions to take to help protect yourself or others from exposure is when you're doffing your procedures, or make sure that you're removing potentially contaminated clothing inside of itself, as well as get any equipment that needs to be deconned as well. Avoid using any hand sanitizers or other products containing alcohol, as it may enhance absorption of some nerve agents and possibly even spread the agent. Also, do not use any bleach to decontaminate the skin. You should wash the affected area with copious amounts of water and soap, and then avoid any contact with the decontamination runoff. There are 5 pre-hospital actions you can take after recognizing an individual has been exposed to a nerve agent. 1 is terminate the exposure. Remove the person from the environment. That's step number 1. Number 2, support ventilation, fresh air, and oxygen as needed. Number 3 is provide atropine therapy. We'll talk more about this treatment later on in this module. Number 4 is provide oxamine therapy in the form of 2-PAM, also to be discussed later. And then also provide any anti-seizure therapy as necessary, which we'll discuss momentarily. If you are tasked with assisting with patient decontamination, remember that decontamination is considered a medical countermeasure. It's designed to protect the health care of the patient as well as the healthcare of you as a responder and healthcare providers at receiving facilities. In addition, it also protects the community health by maintaining the integrity of the healthcare system infrastructure by making sure that you're not bringing any of the agent into the hospitals. Stopping exposures include clothing removal, as well as following any additional dry and wet decontamination steps. Evacuating from the exposure area or sheltering in place to protect the exposed area may be included in some of these decontamination processes. There are some national planning guidance documents that are available for communities to review, and they're focused on addressing the complex local systems as well as risk assessment and prioritization that has a great impact on the community. Emphasis on decision-making and need for training and tools, as well as communication and coordination within the system. Some of the better known documents that are available are included from the Department of Homeland Security and Administration of Strategic Preparedness and Response, or DHS and ASPR. In addition, the Medical Countermeasures through the Department of Health and Human Services has also published a document. Those links are provided on this slide. Now that we've discussed patient decontamination, let's talk about treatment. The focus on treatment for someone that's been exposed to a nerve agent should focus on antagonizing the excess acetylcholine, restoring the function of acetylcholine esterases, and treat medical complications of the nerve agent toxicity. So, in plain language, you're stopping the nerve agent from doing more damage, restoring the body's ability to fight back, and you're treating additional complications that are seen as a result of the exposure. For the response to the excess acetylcholine, we use atropine. It antagonizes the effects of the acetylcholine, and large doses are needed, either given IM or IV. And then in addition, 2-PAM is needed as a cholinesterase reactivator. This is also given IV or IM. To treat a patient that has been exposed to a nerve agent, the atropine and 2-PAM that is administered, the atropine treats the sludgem symptoms, and then the 2-PAM will actually be an antidote for the effects of the nerve agent. There are actually 3 drug or nerve agent antidotes included in the CHEMPACK to administer to the patient. There are several nerve agent antidotes that, if administered soon enough, can reverse the effects and alleviate the symptoms of nerve agent exposure. The 3 nerve agent antidotes included in the CHEMPACK are atropine sulfate, 2-PAM, and then diazepam. The atropine and 2-PAM are used to chemically reverse the effects of the nerve agent on the body, while the diazepam is effective in treating any seizure-like activity seen as a result of the nerve agent. The photo in this slide shows a Mark I autoinjector, which contains both the atropine and the 2-PAM. Autoinjectors facilitate the timely treatment by providing simple, accurate, and rapid drug administration, as they contain pre-measured, controlled doses of the nerve agent antidotes. Moreover, there are no vials, ampules, or syringes to manipulate. The Mark I and Duodate autoinjectors are fully automatic and designed of a rugged construction. They're FDA approved for use by emergency medical personnel in the event of an accidental release of a nerve agent or pesticide. At times, duodotes may be included in the CHEMPACK, but for now they are included for our regional pharmacy cache. The duodotes are available in many of the Northern Virginia response units, and the deployment may vary based on the jurisdiction, but primarily deployed as forward deployed assets on medic units. Each single dose duodote autoinjector contains atropine and 2-PAM, just as a Mark I injector does. If a patient is experiencing some mild symptoms, then they may see miosis, which is pupil constriction, dim vision or room darkening, as well as a headache, runny nose, salivation, and tightness in the chest. These symptoms can occur within seconds to minutes after the exposure. For patients experiencing mild symptoms, such as those that we discussed, there are some dosing recommendations. If it's meiosis alone, the pupil constriction alone, then there may be no need for an antidote. The patient should just be continued to be monitored. However, if you do have pupil constriction coupled with other signs and symptoms, the most common treatment is the MARC1 nerve agent or a duodope, as they contain atropine and 2-PAM. Multiple doses may be needed in order to alleviate the symptoms, and the patient should be monitored in between. For patients that have had a more significant exposure, they will exhibit additional signs and symptoms that will be coupled with the meiosis and dim vision as discussed on the previous slides. In addition, they will experience severe trouble breathing or apnea, as well as generalized muscular twitching, weakness or paralysis, convulsions or seizure, as well as loss of consciousness and loss of bladder and bowel control. There are two options to treat patients that have been exposed to nerve agents that are having severe symptoms. One is an antidote treatment regimen as option 1 that may include IM or auto-injector atropine at 2 milligram doses repeated every 2 to 5 minutes until the patient's signs and symptoms start to improve. That includes the decreased secretions, breathing gets more comfortable, and airway resistance has returned to normal. In addition, they should be given 2-PAM every hour for 2 hours, and it may be necessary to invoke a continuous infusion, but usually that's outside of the pre-hospital realm. Option 2, which is also more often used in the pre-hospital realm, is either the ATNA or MARC1 injectors or the duodopes. This you can repeat the doses every 2 to 5 minutes for 3 doses and then reevaluate their patient. For patients that have been exposed and have severe symptoms, if they experience seizure-like activity, unconsciousness, or diffuse muscle twitching, diazepam or midazolam should be indicated for all these patients. If used early, atropine may function as an anticonvulsant. However, the benzodiazepines are more effective for the seizure medications for nerve agent toxicity. If available, IV administration of diazepam is the preferred route for the treatment of seizures. The overall treatment dosage chart seen here, published by the CDC, is available for review at the attached website. You'll note that pediatric dosages are smaller and should be used when available, and there are limited quantities contained in the CHEMPACK. Medical management of additional complications may occur due to the exposure to a nerve agent. Maintenance of the airway is extremely important, including suctioning secretions, if necessary, intubation and ventilation, and supplemental oxygen may be used. Treatment of seizures, diazepam or a benzodiazepine to stop the seizure activity should be given IV or IM, and then you should be monitoring and treating for shock if it occurs. Medical management of nerve agent patients is extremely important, and a simple way to remember what needs to be covered is A, B, C, D, D, as in airway, breathing, circulation for supportive care, decontamination, and drug therapy. A few additional points to remember about the medications are atropine and 2-PAM are available together in the same, either duodote or ATNA. Those terms are interchangeable. Atropine comes in 2 milligrams, 1 milligram, 0.5 milligrams, and 0.2 milligram availability, and 2-PAM contains 600 milligrams. Diazepam AI is called a convulsant antidote for nerve agent, or CANA, and midazolam or lorazepam are not currently produced in this form. When they're given IM, midazolam is absorbed much more rapidly than diazepam. More repeated dosing over a longer duration may be required to treat fourth-generation agents compared to other nerve agent poisons. With fourth-generation agents, medical management guidelines are extremely important to provide supportive care and symptomatic care as the key. Meticulous attention to supportive and symptomatic care is the key to managing these patients. Continuous monitoring can't be stressed enough. Fourth-generation exposures may be resistant to initial and typically recommended medication doses, and they require significantly higher doses for a longer duration of time to be repeated over other nerve agent exposures. As we conclude Module 2, a few key points to remember is that saving lives in a nerve agent exposure is absolutely possible. The medication approach makes it very easy for us to be able to manage these patients as long as we continue to monitor them. However, time matters as swift action saves lives. Response to nerve agents is a local response. Making sure that we have access to duodotes and CHEMPACKs is extremely important. Patient decontamination should be used as a countermeasure to not relocate the disaster. And federal support does exist with tools, guidance, best practices to optimize local response capabilities. And they should be reviewed on a regular basis. Finally, wrapping up, there's a few questions you should be asking yourself that you should have picked up. We have covered the 5 steps and details to provide an individual that has been exposed to a nerve agent. We've included decontamination measures, and we've discussed mild and severe signs and symptoms of exposure, as well as nerve agent antidotes that can be administered to expose to any nerve agent person. This concludes Module 2, and now you may begin following up with Module 3.